Hey everyone. So as you are working through your readings this week, the major points for the readings and for lab are directly related to vision, vision perception, cognition, cognitive perception, vestibular. So I wanted to give you and neurobehavioral. So cognition, neurobehavioral, you'll see a lot of the same terminology and between those two, with those two topics. So those are your big topics for the week. So your neuroscience book goes into more the neuroscience of these topics, and then your Pedretti talks about the functional context of it. So as you go through the readings this week, it's less about evaluation and treatment of visual deficits following brain injury, but it's how do you evaluate and treat someone with visual deficits related to a neurological event. And that neurological event can be multiple sclerosis, brain injury, stroke, any host of reasons why there might be visual deficits, sensory processing disorders, etc. So big picture, as you are learning about diagnoses through your study guides, as we talk about them during class, as we then dive into these performance skills, big picture, when you walk into a room of an evaluation of someone with X diagnosis, you understand that because of this diagnosis, because of what you understand about neuro, what you understand about the brain, what you understand about the structures, what you understand about the progression of the disease processes, what do you need to know about evaluating vision, vision perception, cognition perception, etc. So it's less about the diagnosis, but more like big picture. When you walk into that room, what do you need to know about being able to evaluate somebody? Let's see if this is okay. So I won't go through all of these slides because you can certainly read them. But just big picture, vision is so critical to assess regardless of the diagnosis. We need to start with the foundations of vision. So do they have their eyeglasses? Do they have a premorbid pathology of the eye? Glaucoma, diabetes, macular degeneration, age-related eye changes. I can't see a darn thing without my eyeglasses on. Reading glasses especially. So we need to know these facts when we go into a room, and then breaking it down even more. So if I walk into a room and I know they have a traumatic brain injury, I know because of what I know about the structures of the brain, if they have occipital lobe damage, then I need to assess vision. If I walk into a room with somebody with MS, or I need to do a deeper dive into vision. Somebody with MS, I know that they have lesions in their white matter that could, depending on where they are, impact vision. But also MS has optic neuritis as one of its symptoms. So I know that vision is probably something that I'll need to assess. But big picture, we're assessing with everybody. Because it really impacts our whole systems. Without our vision, there is so much that can be impacted, especially if it's a new impairment. So keeping that in mind. So we need to just briefly know the anatomy of the eye, the optic nerves. We talked about the cranial nerves. We need to understand where the pathways are and how the brain perceives visual information. And then we need to understand that the difference between vision and acuity and anatomy and pathology versus perception, which is how is my brain understanding the visual information that's coming at it. So that really takes in spatial relations and your attention to your environment. So lots of parts of your brain can contribute to that. And then when you have brainstem and cerebellum infarcts or lesions, what does that mean and how does that change vision? So we need to understand the anatomy of the brain. Now Mary Warren, she is like a vision guru, and she created, and there's a diagram in your text, about the hierarchy of visual processing, how our visual processing system develops. So at the very bottom up approach in this case, oculomotor control. We need that before we can have visual attention and the ability to scan and to recognize patterns and to then understand and recall what we're seeing through our eyes. And then big picture, like cognition related to vision and how vision is then impacting our cognition and how cognition is impacting our vision. There's so many great articles related to this hierarchy of visual processing because you have so much reading, I did not give to you, but at some point I highly encourage you to read it as you progress in your career. So what do we need to know? Clients experience a decrease in the ability to use vision, which then can impact their ability to complete daily occupations. It increases their risk of falls. It decreases their ability to participate in preferred activities. It could impact their social participation if they're not able to physically visualize their environment from maybe a low vision perspective, but also from a perception perspective. If they have an inattention to one side or homonymous hemianopsia, where they're only seeing bits of their world. So if they're quadrants, if you think about your eyes in quadrants, you could have vertical hemianopsia, where now you're only seeing the outside of one eye and the inside of another. That's your visual field, and that's very limiting. So how does that impact all of the social participation, all of the participation in general in one's life in being able to participate in occupation? Pretty much just said all of this. Now we will go through some of the subsets of the brain injury visual assessment battery for adults, also known as the MIMAVA. So we'll go through how to do assessments for tracking and saccades, how to do assessments for diplopia and hemianopsias and visual fields. So we'll get into that in lab this week. So when we're looking at interventions, just kidding. Sorry, people. So we're looking at interventions. We want to think about interventions that promote function. So if it's increasing contrast, so making things bigger for somebody to see who maybe has visual field loss, reducing patterns, or increasing the contrast of a color. So the client's not seeing a white t-shirt on a white bedspread, but you're changing up you're moving that white t-shirt, instead of putting it on the bed, you're putting it in a chair so that they're able to see the contrast of color. You're increasing the font size, you're increasing the darkness of the font. Maybe with your client who's got attention deficits, you're using some sort of anchor on the page or in their environment so that now they know when they are not seeing something on their, let's say, left side, that define that anchor, if it's a color or something tactile that they need, that they can touch so that they can then anchor themselves to that side of their world. Using cues, some form of cues, if it's visual cue, verbal cues, tactile cues as well. Increasing the illumination, so the quality of the light to brighten up the environment. Maybe that will help them see. So just thinking these small compensations that you can make, these small adjustments to one's environment, really will then increase their ability to be safer and function a little bit more independently in their environment. So specifically, I'm not going to go through all of the deficits and assessments because we are going to go through all of this weekend, but thinking about visual acuity, I'm pretty sure at least half of you have some form of acuity deficits in farsightedness or nearsightedness with some sort of correction, if it's glasses or contact lenses or LASIK. So just understanding what visual acuity is near, far, and what is art assessments, what that looks like, and then what assessments for that are, and then what the intervention could be. And some of these interventions, remember, you're not going to be able to do. You're not an optometrist or you're not an ophthalmologist. So this is a client that you may need to make a referral out to another source because you know they need to get their eyeglasses because they got broken in the accident. They need to have an eye exam because they've got new diabetes that had been uncontrolled for a long period of time and now they're having diabetic retinopathy changes. So these are things that you begin to understand about somebody who has visual deficits. But we're always assessing their performance related to these visual deficits because you might find that with these interventions that we've just talked about, that they're very independent and very functional. Or they might be able to compensate independently for those visual deficits. So we need to kind of process with the client as we're assessing their skills, what are they able to do? How does the visual deficits affect their function? What can I do? What are they compensating with for their ultimate success? So we talked about the acuity and that system, now ocular motor function. How are the eyes working together? Binocular vision is a very important part of being able to have depth perception, spatial relations. So if their eyes are not working congruently, they're not converging or diverging appropriately, there might be some form of double vision or diplopia. You might see eyes that are not aligned correctly because of weakness. So how does that impact function? And then what can we do as the therapist to help, if not fix it, correct it, or make recommendations to somebody who can, such as a neuro or behavioral optometrist or ophthalmologist. So that could be occlusion, and we'll talk about that in lab. So if somebody has diplopia or double vision, partially occluding their vision with some sort of translucent tape on a set of eyeglasses can go really far towards helping the eyes start to work together to be able to limit some of that double vision. Patching is not a thing. If you ever have a client who comes to you with a patch, you need to first find out why. What is the need for it? And then potentially find an alternative because patching has been shown to be a not great modality for recovery of vision. Prisms and lenses, those are usually prescribed by an optometrist or ophthalmologist. Eye exercises, a whole host of different eye exercises that we can go through that you can recommend to a client, and sometimes ultimately surgery if the visual alignment of the eyes or whatever the deficit area is too much that it's not controlled or fixed, for lack of a better term, with exercises or these other modalities. So our role, I feel like I've just said that, but this slide really sums it up. We're enabling our client to be as safe and independent in their environment as possible by first assessing what those visual deficits are, first with premorbid or pathologies of the eye, to functionally what are they doing, and then those strategies that we can recommend to them to be independent and safe in their environment, and then ultimately recommending them to another party to facilitate their recovery. So visual field deficits, the homonymous hemianopsias I just discussed, is very devastating to someone, and many people, 30 to 50% of people who've had a stroke end up with this homonymous hemianopsia. So making sure that you're always testing for it. If you have a client who's just missing a lot of things, not specifically on the left, but just in general, that might be a good indicator that something that they have visual field loss, and it can be very, very limiting. So these are some other interventions that you might do. Dynavision is a company, and they make several different types of interactive exercise boards with lights and moving targets that the client can work on to improve their visual fields and ultimately their eye strength. Neglect. So neglect and inattention, visual neglect and visual inattention, they can go hand in hand. They can be separate. They can be they can be very confusing to tease out which is which. Visual neglect is where they are just not aware of one whole side of their visual field, which can also include their body, mostly because of sensory losses, and they just have no awareness. If you have somebody who has a gaze preference in one direction, that's a pretty good tip that they have some level of neglect or inattention. I learned the difference, which, you know, I'm not really sure the longer in this career how much of a big difference there are between inattention and neglect. Whereas neglect, they just have no ability to even compensate for that loss of visual field in that, or it's not loss of visual field, of reduction in awareness of visual field, versus an inattention where they can then use strategies to attend to that side. So I feel like they're very, 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 very similar and very hard to tease out which one is which. So I hope that was helpful, and I will see you later.